Good morning, everyone. You are very welcome to the Supporting the Integrated Care Programme for the Prevention and Management of Chronic Disease webinar. The panel will be delighted to receive any questions you may have. Please use the Q&A feature located at the bottom of your PC or laptop screen. If you are using an iPad, you will find this feature located at the top of your screen. Without further ado, I will now hand you over to your host for today, Sandra Coughlin, Head of Training and Programme Design, MECC. Thank you.
Good morning, everybody, and welcome to the webinar this morning. My name is Sandra Collin, and as Jean said there, I work in health and wellbeing in access and integration, and I'm the national lead for our Making Every Contact Count programme. So delighted to welcome you all today to the webinar where we're looking at how Making Every Contact Count can support the integrated care programme for the prevention and management of chronic disease. Delighted to say there's been huge interest in the webinar this morning, so delighted that so many of you are on our webinar today. And we have a fantastic number of speakers who are going to give a range of perspectives in terms of how we can support the prevention and management of chronic disease together. And I'll introduce all those speakers in due course. The format for the next hour or so is that we have a number of those individual speakers giving a range of perspectives, and then we will have a short video to give a service user perspective, and then we will have a panel discussion to hopefully bring all those threads together. So really looking forward to the next hour, and really looking forward to, I suppose, learning and sharing together in terms of what works and what has been effective, and I suppose the background and foundation for the work that we're all trying to do together. So just to set the scene a little bit, in terms of the purpose and aim of the webinar this morning, we know that our population is aging. We know that there is a significant burden of chronic disease in our population. And we know that the risk factors for chronic disease are largely preventable. So there's a huge amount we can do to prevent disease and to support those with chronic disease in terms of managing those chronic conditions. So again, in terms of all of the reform that we're all involved in locally, the key focus for all of us is that right care, right place, right time, and an integrated, seamless approach across all of our services in terms of supporting our patients and our service users. Some of the key kind of foundation stones for all of that in terms of our Making Every Contact Count programme and all of the work that all of yourselves are doing is that relationship piece in terms of our relationship with each other, in terms of how we're working together and working collaboratively, and that relationship we have with our patients and service users in terms of supporting them in a seamless way. Another key foundation is that learning and sharing in terms of what works. And we know that the evidence for Making Every Contact Count is strong. And we know that there is huge positive work happening around the country in different settings. And we're going to hear some examples of that this morning. So just before we kick off with the speakers, we're going to do a short poll just to get your own kind of sense of where things are at. So Jean, if you wouldn't mind sharing that poll with the audience now. We have two questions on a scale of 1 to 10. The first one is looking at how you would rate your knowledge of Making Every Contact Count and how Making Every Contact Count, or MECC, can support chronic disease management, chronic disease prevention and management. And the second question on a scale of 1 to 10, just as we're starting the webinar this morning again, with 1 being not confident at all and with 10 being extremely confident, where would you rate your own confidence in terms of delivering brief interventions in a chronic disease hub setting? So hopefully those questions are visible to everybody. We'd ask you to vote now in terms of 1 being not informed, 10 being extremely informed for question 1. And for the second question, 1 is not confident, and all the way up the scale then to 10 being extremely confident in terms of your confidence in delivering brief interventions. So again, that poll will just stay up for about 30 seconds just to give people an opportunity to click or wherever you find yourself. And we're going to revisit the results of the poll just as we start the panel discussion later in the webinar this morning. So we'll just give it a second for people to complete that, and then we'll move on. So our first speaker today, I'm delighted to say, is Dr. Maria O'Brien, who's the Service Improvement Lead for the Integrated Care Programme for the Prevention and Management of Chronic Disease. Delighted that Maria is able to join us. Maria is going to give us an overview of the Chronic Disease Programme and how Making Every Contact Count can support the work of the Integrated Care Programme for Chronic Disease. So really looking forward to hearing the foundation of all of this, Maria, and then we'll build on that from there as the webinar goes on. So thank you very much, and I'll hand over to you now, Maria. Thank you.
Thanks very much, Sandra. And again, I'm delighted to be here today to, as you say, I suppose, talk about the context of the Integrated Care Programme for Chronic Disease and really the opportunity that there is within the Chronic Disease Integrated Care Programme and the services that are being rolled out across the country to embed Making Every Contact Count and to support people with chronic disease prevention and management. Some of you will have seen and heard some of the messages that I'm going to talk to you about today already. And so apologies for that, but I thought it was really important just, I suppose, to talk about the foundation of the chronic disease programme and I suppose what it actually is aiming to achieve, and I suppose to try and help and identify for people maybe who are thinking about trying to support some of their colleagues out in the chronic disease hubs to implement Making Every Contact Count. So I suppose just in terms of the Integrated Care Programme for the Prevention and Management of Chronic Disease, for those of you who maybe aren't so familiar with the whole Integrated Care Programmes and the clinical programmes part within clinical design and innovation within the HSE, there's a number of integrated care programmes. And I suppose our programme focuses on cardiovascular disease, type 2 diabetes, COPD and asthma, and just more recently obesity. So there are 4 individual clinical programmes which come in under the Integrated Care Programme. Currently, that's the National Heart Programme, the National Clinical Programme for Diabetes, the National Clinical Programme for Respiratory, and since the end of 2024, the National Clinical Programme for Obesity has joined us. So I suppose the focus of the Integrated Care Programme up to now has been around heart disease, diabetes and respiratory. But we will be starting to look at and I suppose encompass and build on including obesity as part of that work as we go forward. So as Sandra mentioned again, I suppose what's the context or what's the need for some of this work around chronic disease prevention and management. And again, some of you will have seen this statistic before, but again, I suppose our objective is around maximising prevention through the Integrated Care Programme, enabling people to optimise their own self-management of their conditions and really supporting the provision of GP-led primary care. So supporting that sláinte care objective of shift left and moving care into the community and maintaining people as well as we can for as long as we can at home in their everyday lives. And I suppose what's the size of the group of people or the cohort of people we're looking at? You know, our population is aging, so it's increasing all of the time. We have 1.3 million people in Ireland living with chronic disease. And I suppose that's the purpose of the chronic disease programme, is to try and support those people. And as our population ages, to continue to support an ever increasing number of people. So this is the model of care for chronic disease. On the right-hand side of the screen, we have
Maria,
the pyramid. Yeah.
Apologies. Your slides are not showing for some reason. So would you mind trying to share them there again for me?
Okay.
You were in a lovely flow there.
I know. Are they sharing now?
Now, yeah.
We have them now. Perfect.
Wait, just 2 moments, yeah. And if you just pop them into presentation mode for me, please.
Yep.
And just give it a moment. And just move to the slide where you need to be. Yes, that's perfect. Thank you very much, Maria.
Always a technical glitch. This is just, I suppose, outlining the pyramid on the right-hand side of the screen, which is our model of care. And I'm going to take you through, I suppose, the different levels of care that are part of the Integrated Care Programme for Chronic Disease. But I suppose our focus today being about putting specific attention and highlighting within that pyramid where Making Every Contact Count has a real opportunity to be embedded into work. And again, on the left-hand side of the screen, we have the model of care, the national framework, which is available, and all of our resources and support resources are available from on the ECC hub on HSE land under the Integrated Care Programme specific section. So just a little bit of history in terms of where I suppose the Integrated Care Programme fits with the development of a number of key health and wellbeing policies, and I suppose a development of approaches towards chronic disease prevention and management across the HSE over the last 10, 15 years, really. So I suppose the initial Healthy Ireland framework called out the really important piece around making every contact count. And following on in 2015, we had the first integrated care programme being established, which was to look at developing the models of care and, I suppose, developing the approach towards chronic disease prevention and management. Shortly after that, the Making Every Contact Count framework itself arrived, and I suppose that very clearly has set out the objectives of trying to embed brief interventions for chronic disease prevention and management across the service, and really sets out, I suppose, the 5 A's and the framework in terms of how that should happen in terms of a patient-centred approach, which has been really, really powerful and still is live and relevant today. Then we had the arrival of Sláinte Care, which I suppose further embedded and set out the role of health and wellbeing and chronic disease prevention and management in terms of achieving the objectives of Sláinte Care. And followed quickly again in 2017, we had our own integrated care model for the prevention and management of chronic disease, which is the pyramid I'm going to talk to you about today. There have been other, I suppose, further service pieces in terms of the national framework for Sláinte Care around the principles of design and models of care, which again has further embedded and supported and built on those frameworks that I've outlined that have come before them. And obviously then, I suppose, the enhanced community care programme and the business case and the funding that came through 2020 has been a game changer for us in terms of providing the funding and resources to implement the chronic disease programme across our services, and particularly focusing on those new element of services within the community, which heretofore would have been delivered through the acute services, and some of those services are entirely new services at all in terms of supporting chronic disease management and prevention. So when we look at the spectrum of services for chronic disease prevention and management, what are we talking about? We're talking about basic health promotion. We're talking about making every contact count. We're talking about early detection. We're talking about general GP care in the community. We're talking about structured patient education and prevention and I suppose chronic disease dietitians and podiatry. Disease registries, again, are all really important in terms of moving more into some of the strategic pieces. But as you can see, we're talking about a spectrum of care from the very earliest opportunity in primary care all the way through to hospital care setting. And I suppose the importance here is that there is an opportunity to embed chronic disease prevention and management through making every contact count across that broad spectrum of services right across the HSE. So again, just a little bit more statistics, and I won't spend too much time looking at these. But we have a population that is growing, and you can see there in terms of the EU what our our increase in life expectancy. We have a really high life expectancy here in Ireland, which is great, but people are living longer, but they're living with more chronic disease, which is again something that is really important in terms of how we support and manage people. Some statistics just in terms of the different lifestyle behaviours. We have 17% of our population smoking, 24% of the population regularly consuming heavy or more alcohol than is I suppose guided with regard to the low risk drinking guidelines. 26% of our deaths are attributable to circulatory heart disease. The proportion of the population that are overweight are increasing, and the proportion of people meeting physical activity guidelines is reducing. And again, as I said, we're living longer with higher levels of chronic disease and morbidity. So looking at the prevalence of the different conditions there across the diabetes, COPD and asthma. And I suppose the other piece which is really important is that often people aren't living with one chronic disease, they're living with multiple chronic diseases. And 40% of people who engage with our services have 2 or more chronic diseases, which again is really important that we kind of take that multimorbidity approach. And again, multimorbidity increases as we age. Again, this is just looking at the financial impact of health spending, and I suppose looking at trying to evolve to meet population need as we age and as we live more with increasing levels of chronic disease. So I'm going to focus now for the next minute or two on this model of care, and I suppose explaining to people what it actually is, what is the care and the services that are delivered at each level of the pyramid, and where the opportunity to deliver making every contact count sits. So there's 5 levels of care, as you can see. The real focus of our model is around enabling GP-led primary care, to keeping people as well as we can at home under the care of the GP for as long as possible. The bulk of care for chronic disease is provided in the community across level 0, 1 and 2, and up to the 3rd level there is acute specialist care, which would be alternative pathways that are delivered in collaboration with the acute hospitals. And there will then at the top of the pyramid be the need for people to attend ED, AMU, and people who have complex care needs with regard to their chronic disease. They will need to engage with acute services, but it's to try and delay that engagement as long as we possibly can, and even prevent people's conditions deteriorating to the point where they need to engage with ED and AMU as a core objective of the clinical programme for chronic disease. So if we start at 0 level, which is the living well with chronic disease, and I suppose this is the really important one where MECC has a real opportunity. So it's about preventing chronic disease. So people who aren't engaged with services yet, who haven't developed a chronic disease, who may have a number of risk factors for chronic disease, and as Sandra's outlined, those healthy lifestyle behaviours, whether people are making those healthy lifestyle choices, that they have an opportunity to try and I suppose stem the impact of their risk factors, and actually maybe reduce some of the risk factors for chronic disease. Again, you have people living in the community every day with an existing chronic disease, and it's about supporting those people to live well. And that's where MECC can be implemented, but it really can be implemented across all of the tiers. The next level of care is general practice. And I suppose one of the big game changers in terms of our own management of chronic disease in general practice has been the chronic disease management programme, which is being rolled out across general practice. And to date, I think we have about 92% of GPs across the country have signed up and have signed their patients who are already diagnosed with chronic disease to actually be part of the treatment programme. So you can see the 3 circles towards the end of the page here outline the different elements of the chronic disease management programme in general practice. So the treatment programme is for people who already have a diagnosis of chronic disease, and they have 2 visits a year with a GP and a nurse, and the conditions that are included there are outlined. Then we also have the opportunistic case finding programme, which has gone live over the last year or so. And this is for people who, again, maybe are exhibiting risk factors or the beginning stages of a chronic disease, but maybe not fully have a chronic disease. And this is, I suppose, where a GP who feels that there's an opportunity to engage with some of their patients and maybe see if they actually have a chronic disease, and actually support their diagnosis and supporting that earlier diagnosis of chronic disease, which we know is an issue up until now, where patients have lived undiagnosed with their chronic disease for a while before they actually have a diagnosis and actually end up being treated for their chronic disease. So that's really important. And obviously, lifestyle factors here are a really important part of that opportunistic case finding programme. And then we have the prevention programme. And this is where when a GP has people and patients attending who are at a high risk of cardiovascular disease or diabetes, they would now be eligible for enrolment with for a visit with a GP and a nurse annually. And once, I suppose, their risk factors are determined, that they would be supported to try and reverse or support and manage those risk factors. And again, some of those risk factors are lifestyle behaviours like healthy eating, physical activity, their alcohol consumption, whether people are smoking. So this is the programme, I suppose, that's being rolled out across general practice. What I have here now are some of the results from general practice, and I suppose what's really important as part of the general practice programme is that making every contact count interventions are embedded in the GP systems. So they're there and prompt GPs and practice nurses to ask people about their lifestyle behaviours as they visit them as part of being engaged in the chronic disease management programme. So we can see here, just again, this slide is just showing you the level of uptake from GPs for the different programmes. And here are some of the results that we've seen. So with regard to lifestyle behaviours. Between the first visit and the second visit, we've seen a 14% reduction in smoking in patients. Between the first and the third visit, we've seen a 14% reduction in people who are being classified as obese and a 45% reduction in people who are reporting inadequate physical activity. And that is due to and recorded through the MECC intervention being delivered by GPs. Again, what we're also seeing, I suppose, is translation of some of those changes into clinical measurements, which is really important, like measurements of hypertension and HbA1c for diabetes. So we're seeing a 45% reduction between the first and the third visit in terms of people's hypertension levels, and also seeing a 45% reduction in people whose HbA1c is greater than 64 millimoles per mole, which is actually really important. And again, similarly, changes in cholesterol for people with diabetes, ischemic heart disease, and people who have multimorbidity with both. Again, also what we're seeing in terms of the impact of the general chronic disease management program is that we're seeing a reduction in the number of hospitalizations for people with chronic disease. And when we compare that to the number of overall admissions to hospitals for all causes, there's been a 16% reduction in people being admitted to hospital with chronic disease over the last number of years versus all other admissions, which again is showing evidence of the program working. And again, a 30% reduction in GP out of hours, which again is showing that people are managing their conditions and being well and staying healthier and happier at home by being managed through their general practice. I suppose the scope for prevention and early detection, what does it look like? So we see here with general practice, there's 29 million engagements or interactions between general practitioners and their patients every year, and across the rest of the service through OPD, ED, we could see and admissions to acute hospitals that there's 5.6 million. So there's lots of opportunity to make this work. The new level of service which has been introduced and funded through the Enhanced Community Care Programme is the 30 ambulatory care hubs, which I know some of you here joining us today are working in. And I suppose the purpose of the 30 chronic disease teams is to provide a bridge between general practice and acute hospitals, where heretofore general practitioners would have only been able to refer patients with chronic disease into the acute hospital to sit on OPD waiting lists, and for further, I suppose, support from a consultant or for further diagnosis or for whatever advice was needed. But with the advent of the community specialist teams, it's about providing timely access for GPs to refer patients to these community specialist teams for more immediate support and review by either a consultant, clinical nurse specialist, or across a range of service for diabetes, respiratory and cardiology conditions, to support people to be discharged back to the GP again without ever having to engage with an acute hospital. So those teams are being established over the last couple of years. There's 30 hubs across the country, 27 of them are fully operational, and each of those hubs is serving a population of 150,000 and linked into an aligned acute hospital. And as I said, the purpose of the teams is to provide equitable and timely access to diagnosis and specialist opinions, and support GP in maintaining people well as we can at home. And I suppose it's within these community specialist teams that there's a real opportunity to embed making every contact count as part of the delivery of the services that are operated across diabetes, respiratory and cardiology. And we're going to hear from an example of how this has happened in one of our chronic disease hubs later on. And again, it's really, I suppose, encouraging to see that this is happening. Just for those of you who aren't familiar with the chronic disease teams, this is the team and the staffing that makes up the team. And in addition to the team in the community, there's an additional 75 new integrated care consultants are being recruited and have nearly all been recruited. So what that means is that for each hub, there is a consultant for diabetes, respiratory and cardiology who works 50% in the community and 50% in the hospital, but who is there to provide consultant support and opinion to the team within the community, and access for the GP to a consultant as well on an ongoing basis, which is really important. Obviously, then again, with the additional health promotion and smoking cessation staff were funded as part of that enhanced community care. And it's really important to take the opportunity to embed that work within the hubs. And additional laboratory and echocardiography and respiratory cardiography staff were employed to provide direct access to GP diagnostics to support early diagnosis and management of patients as early as possible in their journey. So I suppose just in terms of what the key progress to date has been, as we said, the chronic disease management programme is in place, recruitment of the community posts is progressing and accommodation is being provided. So those hubs are being stood up. Obviously the pay and number strategy is impacted on the pace of fully populating those teams, but work is ongoing to support those teams to continue to grow and to deliver the services that they can deliver with the staff that they have actually recruited. There's significant clinical leadership being provided from the clinical programmes and also from ourselves in the integrated care programme across those teams in terms of setting those teams up and supporting some of the key enablers like setting up pathways. The sharing of learning across those teams is really important as well. And we also have ongoing work with the National ICT and with the new Technology and Transformation Office in terms of providing ICT supports and resources while we all wait for the electronic health record to support that integrated way of working across the community and the acute hospitals to deliver chronic disease management and support. And as I say, it's a fully funded programme, which is now a real important national priority. And it really is important because it delivers on the Sláinte Care objective. I suppose as part of all of that, my parting message is that while this is a hugely significant a shift in terms of how we deliver services for chronic disease management and prevention across the health service, it is really important to take that opportunity to make every contact count and to embed that, I suppose, practice around brief interventions for lifestyle behaviours to support people to live as well as we can for as long as they can at home in the comfort of their homes and with their families and with their community. So just before I finish up, I think the technical team there is going to play this video. I suppose it's just showing, I suppose, the impact that the chronic disease hubs have, the services that are being delivered across respiratory services, and also giving you, I suppose, the patient perspective of the benefits of having these hubs and this community service in place. So thank you very much.
So Cooneven was set up as an integrated care center here for one of the CHO9 hubs. And how it works is with 3 services under the roof. We're first to set up with a cardiology, diabetes, and a respiratory service. So the aim of the service is to manage patients with chronic conditions, commonly being like diabetes, congestive cardiac failure, or asthma and COPD. And the idea is to provide the care closer to home, but traditionally patients would have had their respiratory clinic visits in the hospitals, and we would like to provide the same care that they would get in the hospital but outside the acute setting.
Last November I contracted an SRI, which on top of the COPD that I have, I became very ill and unable to breathe. And an appointment came through very, very quickly. And absolutely from the moment I walked in the door, it was peace, quiet. The whole place gave me a sense of, okay, I'm going to be all right here.
These posts for nursing are split across an 80-20, so 80% of our time we're based in the integrated care service here in the hub, but 20% of our time is dedicated to providing a backup service to the hospital as well. So I would have met Beatrice here in the clinic, and then we made sure that we brought her into Dr. Abby's consultant clinic on a Thursday to have her arterial blood gas done, and I would have met Beatrice there in the clinic as well. So I think for her, it immediately put her at ease.
When you're ill, to get these tests done quickly, to know where you stand, rather than being at home months waiting for an appointment with a cardiologist, which was done like that for me. I think that's very important, and that's what you get here.
Taking time off work to bring mum to her appointments was quite a challenge, and the fact that quite a lot of it could all be done in one place at one time was absolutely amazing. And I've got my mum back, which is amazing, and I can't thank the people here enough. It has been just a life-changing experience.
Thank you very much, Maria, and that video and Beatrice's story at the end is really setting the scene for us for the discussion for the rest of the webinar. And just to say, I think you gave a really great overview of the integrated care program for chronic disease. I mean, in terms of outlining the scale of the issue, the progress that's been made in terms of the reduction in hospitalizations, the uptake and the outcomes that you're already seeing in terms of the GP practice. And I guess just the acknowledgement of the investment that's happened in terms of the specialist teams that have been set up, and I suppose calling out the opportunities that we might have now in terms of really taking those opportunities to make every contact count and to support the work and the model of care as you described it so well. So thank you again, Maria. And what I should have said at the start is, and I know it's been in the chat, the chat is open for Q&A or questions to come throughout the webinar, and we'll hope to deal with as many of them as possible when we get to the panel discussion at the end. And the recording of the webinar today will be going out to everybody as well, so the slides and everything will be available to everyone who has registered. So thank you again, Maria. And as Maria said, we're looking at the topic from a number of perspectives, so I'm delighted now to welcome Rachel Meskel from the Midwest. Rachel is the lead for Making Every Contact Count in the Midwest, or a MECC mobiliser is another term, and there are 9 MECC mobilisers around the country leading and driving and supporting the implementation of MECC in our services. So delighted, Rachel, that you can join us and give us the perspective of how that works and your experience of that in the Midwest. And I'll hand it over to you now. Thank you very much, Rachel.
Thanks, Sandra. Thanks, everyone. I'm just going to share my slides, and you might let me know that you can see it. You can see it there, okay?
Yes, Rachel, that's
Lovely.
up there
Thanks
now.
very
Thank
much.
you.
Thank you. So hello, everyone. I'm Rachel Meskel. As Sandra said, I am the MECC mobiliser for the Midwest. I've been on the implementation team for over 4 years now. Like all the other areas, we do our best to keep the process of implementing MECC as simple as possible. I suppose at the end of the day, we are asking busy sites to adopt a new framework, and I believe one of our jobs is to make that process as seamless as possible. So today, even though MECC implementation is the same on every site, I'm really going to focus on MECC implementation in the chronic disease hubs here in the Midwest, and particularly the parallels that occurred between us in health and wellbeing, the health promotion team, and the chronic disease hubs. So MECC implementation supports the strategic priorities of Healthy Ireland agenda, and that agenda involves improving the health of the whole population. So through policies, guidelines, and interventions, there's a focus on the social determinants of health, and then a focus on individual lifestyle behaviour change interventions, MECC being one of those. At the end of the presentation, I'm going to look at a challenge, because no learning process would be complete without an opportunity to learn and grow, and look at how we overcame that. So to get into the bones of the presentation. So in terms of the MECC implementation team, I am a very lucky MECC mobiliser. I have a very motivated and dedicated MECC implementation team consisting of the training team, implementation team, and we have administration support. We started at the start of 2022. The MECC implementation team would have come together then. So at the moment in the Midwest, 14 sites have completed MECC and 13 sites are near completion, very near it. We are passionate about supporting people to make lifestyle behaviour change and to see beyond just the illness, and really want to see people so they can affect real changes in their lives. I suppose we see MECC as the umbrella almost, and underneath that you have all the programs, the interventions, the services such as QUIT, Living Well, physical activity, integrated alcohol. It's a holistic piece for us. It's about maximising the quality of a patient's life, treatment of the whole person, taking into account all of the factors such as social and mental, not just seeing the illness. So what are the parallels then between us and the chronic disease hubs? Because I feel like we very much sort of soldiered together through the process in terms of implementing MECC. As Maria already said, you have the managers, you have the specialists in diabetes, respiratory cardiology, physiotherapists, podiatry, and all the other staff that are there in the chronic disease hubs. They began in the Midwest operating in March 2022. We have 3 sites. We have the chronic disease hub in Limerick, we have Clare, and we have North Tipperary. And again, you have the senior clinicians who are passionate about their subspecialty, and again, that broader enablement piece. So the staff of the Chronic Disease Hub recognise, promote and enhance the patient's ability to take control over their own health and their life. So I suppose if you look at all of us together, we are focused on that patient-centred care and on the implementation of the national priority programmes such as Tobacco Free Ireland, alcohol, positive ageing. And all of these are focused on reducing the incidence of chronic disease. So the Making Every Contact Count implementation process. So here I invite you, and I know they're going to put a link up on the chat. On HSE Land, there is a Discovery Zone. On the search bar, you can put in Making Every Contact Count. And here there is a wealth of information and resources on making every contact count. I have a picture here of the implementation guide, and this really clearly sets out all the steps and the roles of the personnel in terms of the MECC implementation process. I have here as well a one-page process map. I have to say I love these, right? Because what you can see here very clearly are the 8 steps to making every contact count, the implementation process itself. Now, over the next few slides, I will guide you through those steps, but it's just a very clear, simple one-page document that can be sent to staff, it can be emailed, it can be printed, it can be put anywhere, but it'll detail the process for people. So let's look at the different steps. Step 1 and 2, the engagement process and meeting with senior management. So in terms of the engagement process, it's really important to get buy-in from senior management. With the chronic disease hubs here in the Midwest, this was immediate. When the MECC mobiliser, who was different at the time in 2022, met with the operational managers in April of 2022, the mobiliser was able to explain why we need to implement MECC, how we implement MECC, what we need to do, when we're going to do it. And the operational managers bought in immediately and were able to, encourage their staff to come along to the MECC implementation process and to join in. At the very start and to this day, we have had a very good working relationship. Initially, we offered what we called closed training sessions, so you're enhancing your skills, and this really supported the MECC agenda because it brought all of the Chronic Disease Hub staff together. Since then, because we have a lot of the Chronic Disease Hub staff trained, the staff come along to the open training. So now you have this lovely mix of staff from different sites and different services coming together to the enhancing your skills training and able to have that collaboration and that shared learning. So when I'm talking about implementation and I'm talking about the step 3 and 4, there are certain steps within that. So to solidify MECC implementation, it's important to nominate a site liaison person or persons, and also to create a working group. Now, initially what we do is when all of this is established, there is a health promotion and improvement officer assigned to each site to support the implementation of MECC. I also want to just explain a little bit here in terms of in the Midwest, when we were setting up the implementation process, we were using Project Vision, which is an issue management tool. So to set the criteria for the Project Vision and for MECC implementation, they were the steps to MECC implementation. So it was around staff training, it was around conducting brief interventions, it was around monitoring and reporting, and all the other steps that we were going to outline. So as we were implementing MECC, we were also ticking off the fact that we were doing this Project Vision piece. And really it was to ensure that in terms of MECC implementation, we were consistently meeting our goals. That's really what it was about. One of the other steps is about the staff briefing. And in terms of what we talked about earlier, it's important to have buy-in from the top, but it's really important to have buy-in from the staff. And again, here we were really lucky. The Chronic Disease Hub staff were completely brought in. When we would talk about training, they were so forthcoming, they would sign up for training. Often they were the people asking when the training dates were. So they were actually, they were running the agenda. And I suppose all of that is really important, as Maria said earlier. If we really want to make Making Every Contact Count part of the agenda, we have to bring everybody on board. And luckily enough, in the chronic disease hubs here in the Midwest, we were able to do that. So what are the next steps? So staff training is really important in making every contact count. E-learning is available on HSC Land and it covers 6 core modules. You have the 2 behaviour change modules and you have the skills into practice module. You have 4 topic modules: tobacco, alcohol and drugs, healthy eating and physical activity, plus 2 additional modules talking about overweight and obesity and promoting mental health and well-being. And you will receive certificates for each of these, because this is what we do at the start. We get certificates for our e-modules. And then this allows us then to move forward to a 3.5-hour enhancing your skill training, which can either be face-to-face or virtual. So in the Midwest, we evaluate all of our trainings, and then we bring the training team together and we look at the evaluation piece. And for me and for the trainers, and quite often for the staff, I think this is where the magic happens, because you have 3.5 hours where staff can come together and, using the framework, so the 5 A's, which is ask, advise, assess, assist, and arrange, staff sit in a room and they are able to go through, I suppose, uncomfortable questions. So for example, what would you say if you're a staff member and you find it difficult to bring up the conversation around alcohol, or maybe you find it difficult to bring up a conversation around obesity, and you're able to practice this within the enhancing your skills session. What we find from the evaluation piece is that staff, when leaving this training, are far more comfortable and far more confident to have what we call brief interventions. And at the end of the day, this is what we want people to have. We want the staff to be able to have a brief intervention, have this opportune moment that will occur in a clinical setting or in whatever setting that they're in, and be able to talk to their client or their service user and be able to signpost or refer that patient on to another service. So communication is another step that's really, really important. Now, the National Office have created a really wonderful communication booklet around MECC communications. But again, in the chat, we're going to put up a link to a quality improvement document that's available on the HSE as part of the quality improvement toolkit. So it's a communication document that asks you first, who do you want to communicate to? What do you want to communicate to them? Why are you communicating to them? How are you going to communicate to them? And when are you going to communicate to them? It actually gives examples as well. And again, remember, we have the Health Promotion and Improvement Officer that is going to help the site create their communication plan. There's also, again, resources available on healthpromotion.ie in terms of communication. There are posters, there are leaflets. Again, there's a wealth of resources available to sites and to clinicians who want to use resources when doing their brief interventions. Okay, so the site implementation and the monitoring, these are the last 2 steps. We ask each site to create an action plan. And again, the dedicated Health Promotion and Improvement Officer will support the team to do this. To make site implementation even easier, here in the Midwest, we created a 1-page signposting document that lists trusted sources both within the HSE and external to the HSE. In terms of a national piece, there is a 12-page signposting document. Now, we share both because there's such a wealth of information on both of these documents, and it's just important for staff. I know this from staff in the Chronic Disease Hub and in all other sites. As staff, we want to be able to trust the referral process. We want to know that wherever we're signposting people to, that's the correct place that they need to go, that we're giving the correct information all of the time. So the last step in your MECC implementation process is the recording, monitoring, and evaluation of MECC. And again, I know I say they're all important steps, but this is the analysis piece. Like, why are we doing what we're doing? Are we doing it correctly? Are we meeting the goals that we set out in our communication plan, in our action plan? Is there anything that we need to do differently? If we're going to do so much work to put a MECC implementation process plan and a framework in place, how are we doing with that? Is it working? And this all leads to sustainability. As we said earlier, we want MECC to be part of the culture. We want people to have brief interventions as a matter of protocol, like as they do all the other pieces of work that they do. And by following all these steps, this is how we're ensuring the framework and making every contact count. So the results. How many meaningful brief interventions are we having on a daily basis with our clients or our service users? Are they leading to signposting? Are they leading to referrals? Are we using other services? And really, are we seeing a reduction in people in terms of chronic disease, but also in a reduction in people maybe using our hospital services. What we know from the chronic disease hubs is that they are using a recording tool, and what I might say recording tool, they are recording their brief interventions in their patient notes. Every site, some do their recording differently, some do paper notes, some do online recording. It's up to each site to decide that, but we know in the chronic disease hubs that they're using their patient notes. So I mentioned at the very top, and this is my last slide, about the challenge to the chronic disease hub and working with us. And when I say challenge, I suppose opportunity. What we realized, well, at the start when we were setting up, it was great that we had the chronic disease and us learning together. So we had a health promotion officer attached to each site. About a year and a half ago, we all met because the chronic disease hubs in the Midwest work so well together. So Limerick, Clare and North Tipperary really work very, very closely. We had a health promotion officer, attached to each of these sites, and we realized that actually we were doubling up on our messages. We had too many messengers and too many messages going in. So we met a year and a half ago, and we were able to scale back because now we were set up. They were having their brief interventions. MECC has been implemented. A lot of the initial work has been done. So now we're able to scale back on the number of health promotion officers that we have, and we're able to scale back on the level of messaging that we need to send in there. So that was learning for us. We've actually used that same learning on other sites. We had disability sites as well. And again, we were able to scale back on the number of HPNI officers eventually and on the number of messages we're going in. So I hope that my presentation was helpful to everybody. I know that I'm going to be on the Q&A panel at the end. So I'd like to thank you for listening, and I'm going to pass you back to Sandra. Thank you very much.
Rachel, thank you very much for that. That was fantastic. I mean, there is clearly really good work happening in the Midwest, and you've done a great job of sharing that. It really struck me just at the start when you just mentioned the holistic kind of approach to the patient. And the quality of the patient's life. And again, I guess that's the foundation stone for everything that we're trying to do. And there was a huge amount there in how you described the step-by-step approach. And again, hopefully we will get to talk about it in the Q&A, just how that support has evolved as well in terms of the changing landscape. And as more people are trained and as sites start to implement the approach, that the support evolves and develops with it. So thank you very much. That was really great. And it really reflects the work of the MECC mobilizers or MECC leads that are in each of the areas around the country within health promotion and improvement and health and wellbeing. So really great work happening, and you gave a great showcase of that. So thank you. So now we're moving to another regional perspective, and again, really important now to get the clinical perspective. So I'm delighted to welcome Tina O'Connor, and Tina is a senior physiotherapist for cardiology in the Chronic Disease Hub in Kerry. So Tina, really delighted to hear your perspective on making every contact count in the Chronic Disease Hub in Kerry, and I'll hand over to you now. Thank you very much, Tina.
Thank you, Sandra. So I'm just going to share my slides here. Okay, can everyone see them?
Yes, Tina, we can see them.
Thanks. Okay, so as you said, my name is Tina O'Connor, and I'm the senior physiotherapist in cardiology with the Chronic Disease Hub in Kerry. I'm just going to speak with you today about one recent experience I had when using the MECC approach with a service user. First, I'm just going to give a quick overview of our service. I work in cardiac rehabilitation alongside the cardiac rehab coordinator. Our service users are people who've had problems with their heart, such as those who've had a heart attack, heart surgery, or heart failure, just to name a few. When they first join our program, they undergo a pre-assessment where we ask them to complete several health questionnaires and also some fitness tests. They then join our exercise and education program, which takes place twice a week over 8 weeks. And finally, they complete a post-program assessment where we repeat those questionnaires and the exercise tests and compare them to their pre-assessments. So the service user I'm going to speak about today is a 42-year-old man who 3 months prior to seeing us had an NSTEMI, which is a type of heart attack, and he also had a stent placed. He was a smoker until his event, and he had no other medical conditions. Over the course of our initial assessment, we learned that he had significant stress, both in his work and personal life. He also had poor sleep as a result. So inspired by our MECC training, we decided to ask all of our patients about their alcohol use. And this is the screening tool that we use. It's the audit, or the audit C. might be familiar to some of you. Prior to my MECC training, I would have felt a bit uneasy about asking someone about their alcohol use, as I thought that they would think it's strange that a physiotherapist was asking about this. However, thankfully, now I felt that it was right to ask them about this because it could have a huge impact on their health overall. So our first MECC intervention came at his pre-assessment when so he let us know that prior to his heart attack that he was drinking quite heavily, and even though he had given up alcohol since his heart attack, we still felt it was useful for him to fill out that score that I just showed you. The result would have been 24 based on his previous behaviour prior to the heart attack, and that indicated possible dependence, which is the highest category it could be in. This prompted us to inquire more about the reasons behind his alcohol intake. He told us that he used alcohol to cope with stress, to help him relax and get to sleep, as he often had worrying thoughts racing through his mind, especially at night. We then asked him to complete the hospital anxiety and depression scale, where he scored 12 for each of the depression and anxiety scores, and in each case, this also indicated an abnormal case. So here's just, if anyone's interested, that's the hospital anxiety and depression scale. That's what it looks like. So here's where we came across our first challenge. First of all, a big challenge for us was time. We had a lot of things that we wanted to get through in the assessment, and we felt maybe we didn't have enough time to discuss the issues which were arising in any great depth. Also, in terms of our scope of practice, we're not psychologists, and therefore we felt we had limited ability to address the stress and dependence issues which were being raised. Thankfully, at this point, some of my MECC training kicked in. I felt confident in asking permission to ask about his mental health challenges. I remembered also the benefit of simply letting the patient know that we're here to listen. I asked open-ended questions such as, what have you been feeling? And what do you think could help? And I noticed the patient responded well to this and seemed comfortable when answering. It also presented a great opportunity for us to give details about the effect of stress on the heart, which was very relevant to this gentleman's health status. I also remembered that it's okay not to be an expert in all areas and to not have the solutions to all the problems which were raised. I felt confident instead to give some general advice. For example, the importance of connecting well with others, prioritizing what he personally values in life, setting boundaries, and also sleeping well. I felt one of the most useful things I could do was ask the patient for permission to write to his GP to let them know this situation, and he agreed to this. I also remembered the benefit of signposting him towards useful resources. At this point, the patient did not want those further information about the resources. However, I felt at least it had been helpful for him to know that they existed. Thanks to the nature of our ongoing classes, we had the opportunity to check in with this gentleman regularly, even just on an informal basis to see how he was doing. Unfortunately, about halfway through the programme, this man had an event which led to a hospital admission. When I visited him in the emergency department, he told me that he had been very stressed over the past few days, where he did not sleep, worked all weekend, and had not been eating regularly. I reflected back to him that how these behaviours came right before his recent cardiac event. He actually just laughed and said he was beginning to see the connection between his stressful life and his health. Thankfully, he was discharged from hospital after about a day, and he was cleared to return to our cardiac rehab classes. This man completed the course very well with excellent attendance. His fitness levels hugely improved, and he continued to abstain from alcohol. His depression score slightly improved. It was now at a 10, so it moved into the borderline abnormal category. However, his anxiety score was 11 and still in the abnormal case. At this point, we revisited the option of an onward referral for help, as he expressed some and at which point he expressed some concerns he had about counselling. We addressed these, and he seemed to be open to considering it, and he took details for the Irish Association for Counselling and Psychotherapy. We also reminded him that his GP was now aware of his situation and would be a good person with whom to continue the conversation regarding his mental health. So after this, I just don't know how this gentleman's life is going. I do hope he benefited from this approach, as at least now he's aware that healthcare providers are happy to discuss issues such as mental health concerns and dependency issues. I also hope he will someday take steps to address his stressful life, if not immediately, then at least maybe further down the line, which would allow him to have a better quality of life and less risk of future adverse health events. Thank you.
Thank you Tina, and it's absolutely great to get that patient perspective and that clinician perspective in terms of making every contact count in action. And you clearly had a great rapport with that patient in terms of how you've described it. There's a huge amount there in terms of the description of that scenario with that patient involved. And again, I really like the way that you flagged you don't have to be an expert in everything. It is about being able to recognize where to signpost, or where you can find that information, and where you can signpost and support people to find that information, because again, there are a huge amount of supports and services out there that you can link with, and joining all those dots up is part of what this webinar is about today. So thank you very much, Tina. That was really fantastic, and thank you. And I suppose just building on the description from a patient perspective that Tina just described there in the cardiology service within the Chronic Disease Hub in Kerry, we're now going to show a very short video, just again to reinforce that kind of patient and service user perspective in terms of making every contact count. So Jean, I'll hand over to you there now. Thank you.
I had thought about making changes, particularly with my eating habits and trying to lose weight, because they were causing me problems. And I was very fortunate when I was in for an appointment, in nice friendly chat, brought up had I thought about my diet and making changes, and was extremely helpful.
It's not easy, but take one day at a time, and soon enough you'll eventually get off. I feel proud of myself that I gave up the fight, that I achieved something that I wanted to do.
Active, healthy me has taught me that exercise can be fun, and I love doing dance workouts with my friends. I felt good, everyone's lovely here. Through taking part in Healthy Food Made Easy, I learned how to put more iron and protein in my diet so I have more energy, because it keeps you fit and it helps my mood too.
Okay, thanks, Jean, and thank you to the services and the service users featured in that video, because it is really great to remember what we're all trying to work together to achieve in terms of supporting our patients and service users in the best way we can. So now I'd like to invite everybody back for our panel discussion. So we've Dr. Maria O'Brien from the chronic disease, the integrated care program for chronic disease prevention and management. We've Tina, who was just before the video there in terms of the Chronic Disease Hub in Kerry, and Rachel from the Midwest in terms of the MECC mobiliser, MECC lead for making every contact count in the Midwest. Before we start the panel discussion, I might just ask Jean to share the outcome of the poll that we did at the very start of the webinar, just to look at the results. So again, hopefully everybody can see that there in terms of, on a scale from 1 to 10, how would you rate your knowledge of MECC and its role in supporting chronic disease management. So again, we have a range across there. So hopefully the webinar itself and the follow-up resources that have been linked in the chat will hopefully build those numbers in terms of those that understand and know what making every contact count is about, and how it can support chronic disease management in the work that you're involved in your own service. So that's the first question. And then the second question, we might just have a look at that. In terms of your confidence, in terms of delivering a brief intervention.
Yeah, so Sandra, for everyone, it's on their screen, and if they wish to
Perfect.
scroll down, they should be able to see all the different answers.
Oh, perfect. I've just closed it, so I can't
That's
see it,
okay.
but I'll let everybody else look at it there, and we'll plow on. So look, thank you everybody for the presentations. It was really wonderful to get a sense of it, and we had that national perspective in terms of the model of care from Maria. We had the implementation supports from Rachel, and then obviously Tina in terms of the clinician perspective in terms of putting it into practice with the patient within the Chronic Disease Hub. So a huge range of perspectives there. So just building on some of that, Maria, I might start with you. Just in terms of making every contact count, I think people will understand the connection with making every contact count and prevention of chronic disease. But for those who have an existing and a diagnosed chronic disease, how can making every contact count support those patients?
So it's a really good question, Sandra. And as you say, yeah, the link with prevention is very strong and known. But I suppose The other piece that's equally evidence-based is that for people who have an existing chronic disease, making positive lifestyle changes like becoming more active, eating healthily, if they smoke, by stop smoking or reducing their alcohol content, will all support and help them in their chronic disease journey as well. So sometimes the escalation or the exacerbation of their conditions is made worse by the fact that they haven't been maybe making those healthier choices, but by making those healthier choices, oftentimes there are really positive impacts on their chronic disease as well, and it supports them to feel better in general while living with their chronic disease. So it won't cure their chronic disease, but it will certainly help them feel an awful lot better on a day-to-day basis and help them to manage their chronic disease. So I think that's why it's really, really important for people in the chronic disease, for patients who are in the chronic disease hubs, to have access and I suppose interventions around brief interventions. So I think that's really important.
Yeah, no, that's really great. And it kind of builds on, as Rachel was describing, just that kind of quality of life for the patient as well, in terms of that the
Absolutely.
whole person, and looking at the, rather than just the chronic disease or the condition, that it's looking at the whole person. So Rachel, building on that, just you mentioned in terms of I suppose the huge amount of work that's already happened in the Midwest, and as staff have been trained up, and as the new structures in terms of enhanced community care and the specialist teams have been established, that the support required and the way that MECC is supported and implemented locally has evolved a little bit. So do you want to say a little bit about that in terms of how you keep that momentum, how you sustain MECC in action as the sites move from their initial flurry of activity around training and getting organised and going live with it, to keeping that built in and embedded in the work that's happening within the service?
Yeah, thanks, Sandra. I suppose, look, the key thing here, I think, is the relationship. I think we, as I said earlier in the presentation, we started really well in terms of the relationship, and that has continued. I think a consistent communication from ourselves to the staff and the chronic disease hubs. Like, just I'll give you a simple example. Every 2 months we have created an email, and on the email we send new resources as they become available. So we send that out to anyone who's done the Enhancing Your Skills training, and at the bottom of the email we have put, if you don't want to receive this email, please let us know. And no one has ever come back and said no. So what we do is we're constantly finding new resources. So I suppose it's just that updating, Sandra, as well, keeping people informed about other services that are coming online. I think the fact that the chronic disease hubs have really become more established themselves, and they sort of, they've grown as well as much as we have grown. And I think because we are the health promotion and improvement, and we're also health and wellbeing, like, we've grown in terms of the services that we offer. So we're consistently going back, we have a new service, or we have this, we have the Living Well program, or these are the dates and these are the times. So it's that constant toing and froing between, because we're basically helping each other at the end of the day is what we're doing. So that, I think, really, and I think as well, just the fact that I think we're both so serious about what we do in terms of that chronic disease piece, and that reduction. So when we're working with each other, we're always looking for new ways. Like, I work in a building here where there are primary care staff down another corridor. And what's lovely for me is I've had knocks on my door with staff going, we're running a diabetes training during the summer, a 6-week. So we want to get trained in MECC. We think that's really important. And they went and trained in MECC, and then they knocked on the door again and, have you any leaflets about this? Do you know what I mean? Like, so I think that's the fundamentals. Like, we're all really serious about what we do. So we're always looking for something new and a good angle and a good support and a good education piece. And I think that's the magic, really. Do you know what I mean? Like, we've come along the journey together, Sandra, I feel, and we're continuing it. And I think that's the sustainability piece. Yeah.
Yeah, that sounds great, and that knocking on the door and that kind of connection between staff is again part of the focus of today, is about that kind of sharing information in terms of I suppose that shared learning and working together, because we all have the shared objective in terms of supporting our patients and service users. So you described that very well, Rachel, and you mentioned the training, Rachel. So I'm going to go to Tina now, just in terms of the the Making Every Contact Count program, a key element of it is the training, the online training, and then obviously the Enhancing Your Skills workshop, which kind of builds on that and helps people to build their confidence and their skills around putting the brief intervention into action. So Tina, just from your own perspective and from your own perspective from the hub in general, do you think the training has helped, or how would you think the training has contributed to supporting brief interventions in your setting?
Yeah, I think it has hugely helped, because what I find is we're all speaking the same language. We're very lucky that our teams, we're multidisciplinary, but also we've different service areas we work in. So over lunch, I might be speaking with the diabetes team or the respiratory team, and we'd be kind of chatting about how our services are going. And then we might mention something like, for example, oh, we're using the Audit C, and it really helped identify that gentleman. And actually in that instance, I know the pulmonary rehab coordinator thought, oh, that's a good idea. And then she started implementing it with some of her patients. And then she was also able to come back and say, oh yeah, actually we discovered this gentleman, I wouldn't have thought it, but he was consuming risky levels of alcohol. So I think it's really good that it's just something that naturally that we can talk about, even in an informal setting. And ultimately it does lead to, I suppose, richer conversations with our patients, and that hopefully we are making a difference in their lives.
Brilliant, Tina. And I think you've mentioned it there in terms of some of the tools that can be used that I suppose you get comfortable with and confident to use from doing the training. And I know that Rachel mentioned in her presentation as well in terms of the Discovery Zone, where there's other resources and supports around in terms of I suppose just that kind of toolbox of resources to kind of provide a backup to putting the brief intervention in action in the different services and settings. And just on that, Rachel, I might go back to you just in terms of the signposting piece, because I know that came up in Tina's presentation. I know it came up in your presentation as well. Just in terms of, you described the development of kind of signposting documents within your own work in the Midwest. So can you just say a little bit about how we can kind of build or support people to kind of think about signposting as part of their day-to-day work?
So we developed a one-page signposting document, Sandra, under the headings of physical activity and mental health and tobacco and all of that, using the HSE trusted sources document, because it's really important that when we're signposting that we're all okay with where we're sending people. But I do know from going into sites that a lot of them are already signposting. Do you know what I mean? They have maybe someplace near or whatever that they are comfortable using and they use all the time. So a lot of sites actually sort of maybe further developed our signposting document and added some pieces to that. And that's an okay thing to do, Sandra, because, maybe it's an older person service and we wouldn't have that necessarily on our one-page signposting document, but there's some, services that they're regularly signposting to. So you can create, more of a signposting document, if you know what I mean, but again, using that whole trusted services. I know when I worked in the north side of Limerick, when I was a stop smoking advisor, initially we were a MECC site. And I just went around the north side of Limerick City and went, okay, there's an FRC and a CDP and all these different, and I just got to know them and I suppose a lot of that knowledge is on the ground. So the staff listening to this now and they're probably thinking, can I send someone there? Can I send someone here? And I think if you stick to the trusted sources, can we stand over where we're sending people, then make that part of your signposting document. I would actually put it into the action plan, Sandra, for people. So in your action plan, who are you signposting to? Where do you want to signpost to? And create that as a piece of the action plan, that we're going to create our own site signposting document using what's available. And again, Sandra, that one that's on the Discovery Zone, the national one, because that has all the national addresses in it, where to signpost people. And that's another good resource as well. So you could sort of pool all of those together. That would be really good.
Brilliant. And that is really great to kind of flag that there are a huge amount of national supports and services available, and then there may be local services as well. So again, thanks, Rachel. That's really great. We have time for one last question, so I might just go to you, Maria, for the last question. And again, it came up in your presentation, and I guess just that the outcomes and the evidence is clear, and that the outcomes from the work that's already happening is clear. So is there anything you'd just like to say as a kind of a final word in terms of the evidence for this work and how we can build on it?
Yeah, I mean, I suppose look, the oftentimes, you know, even when I was working in the role, and I know you probably still get asked, what's the evidence for making every contact count? I suppose making every contact count is our brand. What we're delivering are brief interventions, and the evidence is unequivocal in terms of that it does work, and there's, you know, such significant evidence has been put together by the WHO in terms of the evidence of brief interventions. I think one of the things that we're doing really well here in Ireland as well is that we're contributing to that evidence base, particularly in the approach that's been taken to rolling out and implementing the Making Every Contact Count programme. And there are some key papers have come from some of the research that are just about to be published, which I think will be really beneficial and useful for people to actually read and see in terms of the benefits of implementing the Making Every Contact Count. And obviously we have the GP evidence of the impacts that it's having. So I think that's really important as well. Just, I suppose, a final thing to say, you know, while we've talked here about chronic disease prevention and management here today, conscious that there's a couple of things in the questions, and that, you know, integrated care in its entirety is about the networks. It's about the old integrated services for older people. It's about mental health services, and there's a couple of people in the question in the Q&A are asking, how do I implement this with my ICPOP, or how do I implement this at my other services? So, you know, I think today has been fantastic because it's shown some really, really good examples of where things have worked in terms of the chronic disease specialist teams. But I expect that we're part of a much bigger community in terms of how MECC is being implemented across much broader scope of services. And maybe there might be an opportunity to share some of that learning going forward, because I think there's huge richness out there in terms of the work that people are doing. It's fantastic. And I just say to people, keep going, because in terms of integrated care, you know, for chronic disease, we know that our aim is about integrating across all services as well, and not just about the chronic disease hub. So well done to everybody, and keep up the efforts.
Excellent. Look, thank you, Maria. And I think that's a really good way to close the panel discussion. And I know we could have had another half an hour, but we have to wrap it there. So just thank you very much to the panel, Dr. Maria O'Brien from the Integrated Care Programme of Chronic Disease, Tina from the Chronic Disease Hub in Kerry, Senior Physio, and Rachel from Health Promotion Improvement in the Midwest, our MECC lead. Thank you all very much for your presentations and for your input to the panel discussion. As short as it was, we ran out of time. So on that note, I might just wrap things up, and just to say a couple of thank yous before we do. Thank you. I've already thanked the panel, but also those that were involved in the videos that we demonstrated today in terms of the services and the service users that I acknowledged already. Just thank you also to the working group who planned the webinar today. And I know Rachel and Maria were central to that, but also my own team in health and wellbeing. So Donna Doyle, who's the project manager for Making Every Contact Count, and Kaylee Manning, our admin support, and Eamon Keogh, who works with us in health and wellbeing on the stakeholder engagement and communications team. So thank you all very much for all of the work. And of course, our technical team in IMS, who are keeping us all sane with the technical backdrop to everything. And on that note, a closing survey will go out to everybody to ask some questions on your experience of the webinar today, which will be really valuable to us to learn from what was helpful and what we can build on as we go forward. And again, hopefully we answered most of the questions through the panel discussion, but any further information required, please contact us, and the details are on the closing slide there. So on that note, thank you all very much for joining. I think it's fantastic to have such interest, and as Maria said, I think it's just keep going, keep it up. There's really great work happening, and it's all about the support and the seamless care for our patients and service users that we're all really committed to. So thank you for joining today, and we'll leave it there. Thank you.